Hello, good evening all. Today in this session, we'll be discussing about the left bundle branch block, the access calculation, and the fascicular blocks. So coming to the first topic, the left bundle branch block. If we see the anatomy of our heart, this is the ventricle, this is the right ventricle, the interventricular septum, and the left ventricle. This is our AV node. This is the bundle of his. The right bundle branch, the left bundle branch, and the fascicles, the anterior fascicle and the posterior fascicle. So we'll be discussing the block of this left bundle branch. In a normal person, if we see lead V1 is oriented somewhere here and lead V6 is oriented somewhere here, and in lead V1 we'll get a QRS which will have a morphology of RS type, whereas in lead V6 we'll get a QRS with a morphology of QR type, which I discussed in my previous video. If we see in this person, if the bundle branch is blocked, this left bundle branch is blocked, how the activation of the ventricles will be, how the ECG changes will be seeing. Initial step in the depolarization of the ventricle is the depolarization of the ventricular septum, which is from left to right in a normal person and is done by the branch of the left bundle branch. But here this left bundle branch is blocked, so the ventricular depolarization will occur in a reverse direction, which will be from right to left. So how the ECG changes will be in lead V1 and lead V6. In lead V1, due to the septal depolarization, now we'll be getting a small negative wave and we'll be getting a small positive wave in lead V6, as the direction faces away from the V1 and towards the V6. Now the next step comes the depolarization of the ventricular muscle as a whole. As this left bundle branch is blocked, the left ventricle and the right ventricle are both stimulated by this right bundle branch now. The stimulation occurs, it begins with the stimulation of the right ventricle and then it spreads to the left ventricle, and the left ventricle depolarizes late. The depolarization start late, and we have to notice one thing, that even the depolarization of this right ventricle has stopped. The depolarization of this left ventricle continues, as the depolarization has started late, and the total ventricular muscle depolarization vector will lie in this direction. In this direction. So in lead V1 we'll get a large negative wave which comes to baseline like this, and in lead V6 we'll get a large positive wave which comes to baseline like this. So in lead V1 we'll be getting QS type of complexes, and lead V6 will be getting R wave. Here we have to see these T wave inversions are secondary T wave inversions. T wave inversions. These are not the primary T wave inversions which are seen in a case of MI. So what are the causes of LBBB? LBBB is almost always pathological. This LBBB, it denotes the strain on left ventricle, which can be seen in hypertensive heart disease, aortic stenosis, aortic regurgitation, or cardiomyopathy, which can be ischemic or dilated. So let us see an example of LBBB. If you see this ECG, here you see in lead V1 you have a QS type of QRS, and lead V6 you have a R wave. So this is a ECG of left bundle branch block. Sometimes we'll have the QRS complexes in chest leads, which will neither resemble RBBB or LBBB morphologies. These are wide QRS complexes which neither resemble RBBB nor LBBB. So what are these? These are wide QRS which do not resemble RBBB or LBBB. Here we use a broad term for this, which is called as interventricular conduction delay. Actually, this RBBB and LBBB are the types of intrinsic interventricular conduction delay. When we cannot differentiate, when we cannot make out which type of defect is this, we give it as a broad term, we call it as interventricular conduction delay. Now coming to hemiblocks, but before coming to hemiblocks, we should know how to calculate the X's on an ECG. So we'll be looking about the calculation of X's on ECG. To calculate the X's of ECG, we should focus on limb leads, which are our leads 1, 2, 3, AVR, AVL, and AVF. The normal axis of heart lies from -30 to +90 or +100 according to various authors. Before calculation of this axis, we should know the orientation of our axis. This is the lead 1, this is the lead AVF, this is our lead 3, this is our lead 2, this is our lead AVL, and this is our lead AVR. If we see the negative leads, this will be -1, this will be -AVF, this will be -AVL, this will be -AVR, this will be -3, and this will be -2. If we see This is our 0 degree, minus 30, minus 60, minus 90, minus 120, minus 150, and minus 180. And this is our plus 30, plus 60, plus 90, plus 120, plus 150, and this is our plus minus 180. The normal axis of the heart lies in between this. This is our normal axis, which is from minus 30 to plus 90. If the axis lies somewhere in this direction, if it lies from minus 30 to minus 90, we call it as left axis deviation. If the axis lies from plus 90 to plus 180 in this direction, we call it as right axis deviation. But if the axis lies in this direction, which is minus 90 to minus 180, we call it as extreme axis deviation. Now the question is how to calculate the axis. We can actually use any of these leads. We can use any of these leads to calculate the axis. Suppose if we can take lead 1 and lead AVF. We can calculate the QRS magnitude and determine the vector in which direction the vector of the ECG lies. That will give us the direction of the electrical axis. Let us take this with an example. If you see this ECG, in this ECG, if you see lead 1 and lead 3, if you see lead 1, the QRS is negative and it has a magnitude of minus 7, and lead 3 has a magnitude of plus 8. So in this ECG, lead 1 is minus 7, lead 3 is plus 8. So if we extrapolate this, this will be our lead 1, which is minus 7, and this will be our lead 3, which is plus 8. So the axis of the heart will lie somewhere in between these two leads, and it will be facing more towards lead 3. So the axis of the heart will be in this direction, and we can clearly see it is more than 90 degree. It is more positive than 90 degree. So this is a case of right axis deviation. If you see this ECG, in this ECG, if you see lead 1 has a QRS of plus 15, and if you see lead AVF has a QRS of minus 14 approximately. So lead 1 has a QRS of plus 15 and lead AVF has a QRS of minus 14. So if we extrapolate these two leads, we have lead 1 with plus 15 and lead AVF with minus 14, which is our minus AVF. So the electrical axis in this case will lie somewhere in between these two leads and more towards lead V1. So it will be somewhere here, which will be almost near minus 45 degrees, as it is more negative than our minus 30. So it is a case of left axis deviation. Sometimes we'll have an ECG in which the limb bleeds will be biphasic everywhere. If we have biphasic limb bleeds, if all limb bleeds are biphasic, then what is the axis of the ECG? In such cases, it is not possible to calculate the axis of the ECG, and we call it as indeterminate axis. Where the axis of the ECG is not possible to be determined, we call it as indeterminate axis. So using this, you can easily calculate the axis on the ECG. Now coming back to fascicular blocks. Fascicular blocks or hemi blocks. Fascicular blocks or hemi blocks, these are the blocks of the fascicles of left bundle branch. Here these bundle branches are blocked, the left fascicle or the right fascicle. If we see the anatomy, the left anterior fascicle, it faces superiorly and towards left, which means in this direction, and the left posterior fascicle, this faces inferiorly plus downwards, which means in this direction. Left anterior fascicle faces superiorly and towards the left. The left posterior fascicle faces inferiorly and downwards. And on ECG, the left anterior fascicular block gives the ECG axis, which is minus 45 degrees or more negative, whereas the left posterior fascicular block gives us an ECG with the axis of plus 120 degrees or more positive. But the problem here arises is how to calculate these figures. For that, again we'll go back to the knowledge of the axial orientation. This is 1 AVF, lead 3, lead 2, lead minus 1, AVL, AVR, minus AVL, minus AVR, minus AVF, minus 3, and -2. If the person has left anterior fascicular block, his axis will be -45 degrees or more negative. So the axis should be more negative than -45 degrees. Then how to calculate? We can take these two leads, lead 1 and lead AVF. We'll see the magnitude of the lead, both the leads. If the magnitude of minus AVF is more than the magnitude of lead 1, then the axis will face more towards lead AVF and it will be a case of left anterior fascicular block. Similarly, lead 3 exactly lies at 120 degrees, so we can take lead AVF and minus AVL. If the magnitude of minus AVL is more than the magnitude of AVF, the axis will face more towards minus AVL, which is more positive than 120 degrees. We'll have a case of left posterior fascicular block. Now let us see this with the help of an example. If you see this ECG, we'll focus only on two leads, lead 1 and lead AVF. Here clearly you can see lead AVF and lead 1. Lead 1 has a magnitude of around +6, whereas lead AVF has a magnitude of around -8. So if we extrapolate this, lead 1 is +6 and lead AVF is -8. So if we extrapolate this, this will be our +6 of lead 1 and this will be -8 of minus AVF. So the axis will be facing somewhere in this direction, more towards minus AVF, which will be more negative than our -45 degrees. So this is a case of left anterior fascicular block. Now if we see this ECG, in this ECG, if you focus on lead AVL and lead AVF, if you see closely, lead AVL has a magnitude of around -8, whereas the lead AVF has a magnitude of around +7. AVL has a magnitude of -8 and AVF has a magnitude of +7. If we extrapolate this, we will have +7 of AVF and -8 of lead minus AVL. So the axis will be pointing more towards lead AVL, which should be more positive than 120. So this is a case of left posterior fascicular block. We can have bifascicular blocks, we can have trifascicular blocks. Suppose if we have a patient of myocardial ischemia and you find a case of right bundle branch block plus left anterior fascicular block. Along with this, if you see first degree heart block, which is PR prolongation more than 200 milliseconds. So this condition signifies that the patient can land up in complete heart block, and we should go for pacemaker implantation. In this ECG, you can see the patient has a bifascicular block. He has an RBBB with left posterior fascicular block. He has a bifascicular block, which is RBBB plus left posterior fascicular block. Then how to see these trifascicular blocks? Suppose a patient comes to you with the symptom of syncopal fall. You do an ECG, you get a RBBB pattern, and after some time you repeat an ECG and you get LBBB pattern. This signifies that the patient has alternating blocks. You can call this as a trifascicular block, where you should go for pacemaker implantation. This pattern should not be confused with ventricular bigeminy, which is a different concept. This should not be confused with ventricular bigeminy. Thank you.